Hi Raju, how are you doing today?
I'm good, Michael, and perhaps you must be busy with the pediatrician's course today. But side by side, let me start with an interesting story. With World War II, the first information on the potential efficacy of anti-malarials in rheumatic diseases was revealed. American soldiers who fought in the Pacific region received antimalarials as prophylaxis. But what happened was that they reported reduction of the severity of lesions and symptoms of arthritis. And this led to further research on the efficacy and application for the treatment of autoimmune diseases. In 1951, a certain Dr. Page, extrapolating from the observations he made, demonstrated a clear success in treating 18 patients with cutaneous lupus, and thus a new era began.
So, this drug has been used for more than 70 years for treating lupus and is still a very important drug for treatment of this disease.
Oh, absolutely, Michael. Patients on hydroxychloroquine have much lower rates of flare, less accrued organ damage, less thrombotic events, and even longer survival. If you know Professor Ramanan from the UK, I recall a talk from him and quote him when he said that hydroxychloroquine should be in the tap water of patients with lupus.
Oh, I hope that it tastes nicely. But what is the main discussion point today?
Michael, it focuses on studying a reference range of hydroxychloroquine blood levels that can reduce the odds of active lupus and prevent flares.
Yes, and we are aware about the American Association of Ophthalmology's guidelines after 2014 study where they noted a higher eye toxicity risk with higher dose of hydroxychloroquine. So the dose they were finding is more than 5 milligram per kilo per day. And so they recommended to use it up to 5 milligrams per kilo per day. But this is a different angle looking at optimal therapeutic range.
Well, the authors build a strong case by showing a meta analysis of studies done till theirs. 13 of the 14 looked at threshold levels. Mark you, threshold levels are not range for favorable trends in disease activity. Less lupus flares, lesser thrombotic events, etc. And the threshold ranges were so wide and they varied from 484 nanograms per ml to 1000 nanograms per ml. And the other one looked at a threshold for retinopathy, which was demonstrated at greater than 1183 nanograms per ml. This is the first study that evaluates a range rather than a threshold level.
So this is a prospective cohort study that included adult patients who met standard diagnosis criteria seen in a rheumatology clinic at the University of Wisconsin-Madison for about 1 year at the height of the COVID pandemic. And they were prescribed hydroxychloroquine for more than 3 months before the visit date, and then they provided consent for the study.
So, at the baseline visit, patients' socio-demographic, clinical, laboratory, and medication data on the day of the clinic visit were obtained from the electronic health records. Clinic notes and laboratory data from the visit were reviewed to calculate SLEDAI scores. On the visit day, patients also reported their adherence using a validated, stakeholder informed adherence self report questionnaire. And on the follow up visit for longitudinal measurements, consenting patients underwent an additional blood draw during this follow up visit. Only 25% of patients were allowed to be seen in clinics or laboratories during the peak years of the pandemic. They thus use something that they call a convenience sampling strategy to collect follow up data and blood samples for HCQ levels monitoring in those who presented for a follow up standard of care lupus visit in the clinics. And the adherence questionnaire was also completed on this follow up day, and medication data were abstracted. Again, clinic notes and laboratory data were reviewed to calculate SLEDAI on the follow up day. They used liquid chromatography and mass spectrometry to measure HCQ levels in blood.
Okay, and for cross sectional analysis that included all baseline visits, the primary outcome was active lupus, and it was defined as a SLEDAI equal or over 6. And for longitudinal analysis that included all patients with a follow-up visit after the baseline visit, they determined lupus flare using the SLEDAI flare index, so the SFI, and only the first follow-up visit was included in the primary and longitudinal analysis. But my concern is because of this heterogeneity of the disease, I'm wondering if a single outcome measure is enough to evaluate the best serum level of hydroxychloroquine.
Well, 158 patients underwent HCQ blood levels, and 42 of their patients completed a follow up visit within 6 to 12 months of their baseline visit. 17% of them experienced a lupus flare. And then they've used complex mathematical analysis. And finally, they conclude that the reference range with the upper and lower bounds for efficacy in reducing odds of active lupus and lupus flare is 750 to 1200 nanograms per ml. Achieving blood levels within this range reduced the odds of active lupus by 71% and maintaining them reduced the odds of flares by 26% over 9 months of follow up.
So, Raju, when I read this paper, I had some questions in mind, but I'm sure that the reviewers would have considered these. Firstly, the authors call it a prospective study, but the patient had been diagnosed and started on medication before the baseline visit. At what stage were they consented? And secondly, they used the word convenience sampling without explaining the term convenience of date of visit or convenience of timing of sampling versus dose administration. And thirdly, unfortunately for them, COVID limited follow to 25%.
True, but nonetheless, Michael, I think the author should be commended on taking this step forward in this possibly important step in adding to the recommendations to manage lupus.
So I have additional concerns. What is the pharmacokinetics in children? And is the serum level really better than the dose per kilo to prevent more flares? To justify such a lab test, what it's considered may be considered as expensive. especially in some settings. And finally, I'm more concerned in practice by the ocular damage because of the long lifespan of our patients.
Very true. But I think to address some of these, there is another article that we have attached in the supplementary material, which is likely to help our listeners. But in the meantime, I do agree with your concerns, but have to say that wherever Dr. Page is today, he would be quite happy to see someone turning a new page on his discovery.
Thank you very much for this, Raju. Goodbye. See you next
Yes.
week.